Dr. Baliga here. This podcast is a multiple choice question preparation for the boards from an outstanding chapter titled Perioperative Medicine in Baliga's textbook of internal medicine, available at mastermedfacts.com. The chapter is authored by Dr. Hugo Quinny Cheng, MD, who is professor of medicine at UCSF. He also completed his medical school and residency training there. He works as a hospitalist with a clinical focus on perioperative medicine. He also directs the Internal Medicine Board Certification and Recertification Review CME course for UCSF's Department of Medicine. A patient is referred for medical evaluation prior to surgery for head and neck cancer. Which of the following findings in his history is least likely to be associated with increased risk for post-operative pulmonary complications? A. Age 70 years old. B. History of snoring and daytime somnolence. C. Asthma treated with inhaled steroids. D. Congestive heart failure. And E. Stroke leading to inability to care for self. And the answer is C, that is asthma. The risk for postoperative pulmonary complications increases with advanced age, chronic obstructive lung disease, heart failure, functional dependence, and obstructive sleep apnea. Mild or moderate asthma does not predict increased risk. Preoperative pulmonary risk assessment. Post-operative pneumonia and respiratory failure are the most significant post-operative pulmonary complications. Some studies also include less clinically relevant complications such as hypoxia, bronchospasm, or radiographically demonstrated atelectasis in their definition of pulmonary complication, inadequate lung expansion after surgery leading to decreased functional reduced capacity, plays an important pathophysiological role in post-op pulmonary complications. Thoracic and upper abdominal procedures cause the greatest impairment of functional residual capacity and lead to the highest risk of post-op pulmonary complications. Prolonged anesthesia time also increases risk. Patient-related factors are myriad. A 2006 systematic review identified age, COPD, CHF, overall severity of systemic disease, and functional dependence, such as assistance needed to perform activities of daily living, and obstructive sleep apnea as important predictors. Mild or moderate asthma does not raise risk. While obesity was not identified as a predictor, it is associated with obstructive sleep apnea, which has recently been identified as a risk factor. While risk assessment tools for estimating postoperative pulmonary complications exist, they have not been widely adopted in clinical practice. Other risk factors for postop pulmonary complications include procedure-related, that is thoracic or upper abdominal surgery, anesthesia time greater than 3 hours, general anesthesia, and emergency surgery. What are the keys to history and physical examination? In pre-op pulmonary risk evaluation, the pre-op evaluation should try to identify the presence of patient-related factors for post-op pulmonary complications, both in the form of established diagnoses as well as symptoms that suggest undiagnosed disease. The STOP questionnaire, STOP, which asks about snoring, tiredness during the day, observed apnea, and high blood pressure, can identify patients likely to have obstructive sleep apnea if at least 2 of these findings are present. For patients with obstructive lung disease, the internist should look for symptoms of exacerbation which may need to be treated prior to surgery. In a case control study, the presence of abnormal lung examination findings, that is diminished breath sounds, prolonged exhalation, wheezing, crackles, or rhonchi, was associated with increased risk of pulmonary complications after abdominal surgery. Diagnostic testing. The role of ancillary testing to evaluate or manage post-operative pulmonary risk is largely uncertain. Routine chest X-ray rarely influences management and is not indicated. In patients with diagnosed lung disease, pulmonary function testing and spirometry add little information beyond clinical assessment. There is no severity of pulmonary function test abnormality that can be used as an absolute contraindication to non-lung resection surgery. Reducing risk of pulmonary complications. The strategies to prevent post-op pulmonary complications have not been studied as thoroughly as those for cardiac risk reduction. Patients with obstructive lung disease should have their respiratory status optimized prior to elective surgery. Smoking cessation prior to surgery has uncertain benefit. Retrospective studies found that the risk of post-op pulmonary complications in smokers can be reduced only if they cease to smoke for at least 1 to 2 months prior to surgery. Due to the role of lung collapse in post-op pulmonary complications, use of lung expansion maneuvers, example deep breathing exercises, or incentive spirometry is recommended for high-risk patients. This short case scenario is from an outstanding chapter titled Perioperative Medicine in Baliga's textbook of internal medicine, available at mastermedfacts.com. The chapter is authored by Dr. Hugo Quinny Cheng, MD, who's professor of medicine at the University of California, San Francisco, where he also completed his medical school and residency training. He works as a hospitalist with a clinical focus on perioperative medicine. He directs the medical consultation service and co-management with neurosurgery service and regularly teaches about preoperative medical evaluation, perioperative medicine to residents and practicing physicians. He also directs the Internal Medicine Board Certification and Recertification Review CME course for UCSF's Department of Medicine.